Dear medical pioneers, today we're diving into a fascinating and critical topic in pathology: neoplasms of the kidney, decoding the mysteries of renal tumors. Your guide on this journey is none other than Professor Dr. Farkhunda Nadeem, head of the Department of Pathology at Faculty of Medicine and Allied Medical Sciences, ISRA University. With one foot in the world of diagnostic precision and the other in cutting-edge AI technology, I'm here to unravel the complexities of kidney tumors like never before. A quick heads up: this lecture is powered by a blend of medical expertise and AI innovation, ensuring you get the most advanced and insightful learning experience. So, grab your notebooks and let's embark on this diagnostic adventure together. Introduction to renal neoplasms. Today, we're diving into the world of renal neoplasms, abnormal growths or tumors that develop within the kidney. These growths can range from benign, non-cancerous, to malignant, cancerous, and they can occur anywhere in the urinary tract. Key fact 1. Benign neoplasms. Now, here's something fascinating. Benign renal neoplasms are far more common than you might think. In fact, autopsy studies reveal they're present in up to 40% of adults. The good news: most of these are clinically insignificant, meaning they rarely cause major health issues. Key fact 2. Malignant neoplasms. Urgency in tone. But malignant neoplasms, that's a different story. These require prompt diagnosis and treatment to prevent serious complications. Most common malignant tumors. So, what are the most frequent culprits? In adults, renal cell carcinoma (RCC) tops the list. For children, Nephroblastoma, or Wilms tumor, is the leading malignant kidney tumor. Surprising comparative statistic. Here's a critical insight many miss. Neoplasms of the lower urinary tract, like those in the bladder or ureters, are actually twice as common as renal cell carcinomas. This underscores why comprehensive urological screening is so vital in clinical practice. Closing. Pathological importance. Strong and authoritative. But no matter the type, one thing remains clear: pathological examination is the gold standard for accurate diagnosis and classification of renal tumors. It's the key to unlocking the right treatment plan, and ultimately, better patient outcomes. Classification of kidney tumors. Let's now explore the classification of kidney tumors, a critical framework that guides diagnosis and treatment. These tumors are categorized based on their cellular origin and behavior, whether benign or malignant, epithelial or non-epithelial. Section 1. Benign epithelial tumors. First, benign epithelial tumors. These arise from two key sites. Those originating in the renal parenchyma are called adenomas. Those developing in the renal pelvis are termed transitional cell papillomas. Section 2. Malignant epithelial tumors. Next, malignant epithelial tumors, which are more aggressive. Here we see adenocarcinomas of the renal parenchyma, also known as hypernephromas or renal cell carcinomas (RCC), the most common kidney cancer in adults. Tumors of the renal pelvis, including transitional cell carcinoma, squamous cell carcinoma, adenocarcinoma, and undifferentiated carcinoma. Section 3. Benign non-epithelial and embryonal tumors. Now, let's discuss benign non-epithelial and embryonal tumors, a diverse group. Embryonal tumors like multicystic nephroma and mesoblastic nephroma. Non-epithelial tumors such as angiomyolipoma and medullary interstitial tumors, fibromas. Miscellaneous but clinically significant tumors like the juxtaglomerular cell tumor, or reninoma, which can cause hypertension. Section 4. Other malignant tumors. Finally, other malignant tumors beyond epithelial types. Embryonal. The infamous Wilms tumor, Nephroblastoma, primarily affecting children. Non-epithelial. Rare but serious sarcomas. Metastatic tumors that spread to the kidney from other primary sites. Closing. Clinical relevance. This comprehensive classification system is the backbone of pathological diagnosis. By understanding a tumor's origin and characteristics, clinicians can tailor treatments more effectively, whether it's a slow-growing adenoma or an aggressive sarcoma. Remember, precision in classification saves lives. Benign renal neoplasms. While malignant kidney tumors often dominate discussions, benign renal neoplasms are actually far more common in clinical practice. Today, we'll examine 3 important types, their characteristics, significance, and why they still demand our attention. 1. Renal adenoma. First, the renal adenoma, a small, well-defined tumor arising from the renal tubular epithelium. Autopsy studies reveal these in 7% to 22% of individuals, making them surprisingly prevalent. But here's the critical detail. Emerging evidence suggests some adenomas may transform into renal carcinomas, hinting at a potential benign to malignant progression pathway. This is why even small adenomas warrant careful monitoring. 2. Angiomyolipoma. Next, the angiomyolipoma, a true histological mosaic. As a hamartoma, it contains 3 key components: mature fat, smooth muscle, and abnormal blood vessels. This unique composition gives it a striking appearance, both grossly and under the microscope, often allowing for confident diagnosis without advanced testing. Fun fact: its triphasic pattern is so distinctive, it's a favorite among pathology residents. 3. Oncocytoma. Finally, the oncocytoma, an epithelial neoplasm believed to originate from the collecting duct's intercalated cells. Accounting for 5% to 15% of renal neoplasms, it's notable for its excellent prognosis, especially when compared to malignant counterparts. However, its gross resemblance to renal cell carcinoma means we must rely on microscopic features, like its uniform eosinophilic cells, for definitive diagnosis. Closing. Clinical takeaway. While these benign tumors are often clinically silent, their potential to mimic, or even progress to, malignancies underscores why pathological expertise is non-negotiable. Remember, in the world of renal masses, benign doesn't always mean insignificant. Delivery tips: pacing. Slow down for statistics, e.g., 7% to 22%, and diagnostic terms, e.g., triphasic pattern. Tone. Conversational for introductions, e.g., fun fact. Serious for clinical implications, e.g., potential to progress. Emphasis. Bolded terms, angiomyolipoma. For retention. Pause after non-negotiable for impact. Renal cell carcinoma overview. When we talk about kidney cancer, one name dominates the conversation: renal cell carcinoma, or RCC. Accounting for a staggering 80% to 85% of all primary kidney malignancies, this is the tumor every clinician and pathologist must master. Key facts about RCC. Also historically called hypernephroma, or Grawit's tumor, RCC arises from the renal tubular epithelium, which explains why we typically find it in the cortex of the kidney. It's a disease of aging, most frequently striking patients in their 60s and 70s, with men affected twice as often as women. Globally, RCC represents 2% to 3% of all adult cancers, a small percentage, but its impact is profound. The 2 faces of RCC. Not all RCCs are the same. They broadly divide into 2 categories. 1. Sporadic RCC. The classic scenario: a single tumor in the upper pole of the kidney, typically in a 60-year-old male smoker. Yes, cigarette smoking is the major preventable risk factor here. 2. Hereditary RCC. This variant targets younger adults, often presenting as bilateral tumors. It's tightly linked to von Hippel-Lindau (VHL) disease, an autosomal dominant condition where mutations in the VHL gene create a perfect storm, increasing risks not just for RCC but also for cerebellar hemangioblastomas. Visualizing RCC. Pathognomonic clue. The gross specimen of RCC often reveals a yellow to orange mass, a hue that hints at its lipid-rich content, a hallmark we'll explore deeper in histopathology. Closing. Why this matters. Why focus so intensely on RCC? because it's the poster child of renal malignancies, common, clinically treacherous, and a window into how genetic and environmental forces collide in cancer biology. Master this, and you've taken a giant leap in oncologic pathology. Delivery tips: pacing, slow for stats, 80% to 85%, and anatomic terms, renal tubular epithelium. Tone shifts, urgent for risk factors, cigarette smoking. Awe for genetic links, perfect storm. Emphasis, bolded terms, Grawitz tumor, VHL gene, for retention. Pause after poster child of renal malignancies, for dramatic effect. Risk factors and classification of renal cell carcinoma. Renal cell carcinoma doesn't develop in a vacuum. It's fueled by specific risks and molecular quirks. Understanding these is key to prevention, early detection, and precision treatment. Let's break it down. Risk factors, the usual suspects. First, the culprits behind sporadic RCC. Smoking, the heavyweight champion of risk factors. Cigarette smoke directly damages renal DNA, doubling down on malignancy risk. Unopposed estrogen. Postmenopausal women take note. Estrogen therapy without progesterone tilts the scales toward RCC. Acquired polycystic disease. Patients on chronic dialysis face a jaw-dropping 30-fold increased risk, a stark reminder of renal vulnerability. Obesity and hypertension. A deadly duo. Hypertension strains renal vasculature, while obesity, especially in women, creates a pro-inflammatory milieu. Cadmium exposure. Occupational hazard alert. Workers in battery production, metal refining, or construction risk cadmium accumulation, a silent renal saboteur. Classification. Decoding RCC subtypes. Now, the molecular taxonomy of RCC. These aren't just histologic curiosities. They guide prognosis and therapy. 1. Clear cell carcinoma, 7,080%. The most common aggressor, born from proximal tubular cells. Its hallmark, VHL gene mutations and chromosome 3p deletions, cornerstones of targeted therapies. 2. Papillary carcinoma, 1,015%. Arising from the renal tubular epithelium, this subtype wears its MET protunca gene, chromosome 7, abnormalities like a molecular fingerprint. 3. Chromophobe carcinoma, 5%. The rarer, calmer cousin. Originating in collecting duct intercalated cells, it's defined by multiple chromosome losses, but paradoxically, a better prognosis. Closing. From knowledge to action. Why does this matter? Because risk factors are preventable, and classification drives cure. Whether it's smoking cessation or choosing a MET inhibitor, every detail here translates to lives saved. Next, we'll see how these subtypes look under the microscope, where science meets art. Morphology of RCC subtypes. Under the pathologist's eye, renal cell carcinomas reveal their true colors, literally. Today, we'll tour the gross and microscopic landscapes of RCC's three main subtypes, where every hue and pattern tells a diagnostic story. 1. Clear cell carcinoma. The golden aggressor. Meet the most common culprit, clear cell carcinoma, responsible for 7,080% of cases. Grossly, it's typically a solitary, unilateral mass, 315 centimeters, favoring the kidney's upper pole. On cut section, a striking yellow to orange canvas, streaked with gray-white areas and often dotted with hemorrhages or cysts. Notably aggressive, frequently invading the renal vein, perinephric fat, or even the adrenal gland. Microscopically, the tumor lives up to its name. Clear cells packed with lipids and glycogen, their small round nuclei floating in this sea of transparency. A visual paradox, beautiful to behold, yet clinically treacherous. 2. Papillary carcinoma. The frilled invader. Accounting for 1,015% of RCCs, papillary carcinoma plays a different game. Key traits: often bilateral and multifocal, a scattering of tumors rather than a single mass. Under the microscope, delicate papillary fronds with fibrovascular cores. Tumor cells that range from pink to clear, their cytoplasm whispering clues about underlying MET protein gene mutations. This is RCC with a signature pattern, one that demands genetic interrogation. 3. Chromophobe carcinoma, the pale prodigy. The rarest of the trio at just 5%, chromophobe carcinoma is the subtype that breaks the rules. Gross appearance. A modest tan-brown mass, lacking the flamboyance of its clear cell cousin. Microscopic hallmarks. Cells with pale eosinophilic cytoplasm sporting dramatic paranuclear halos, like cosmic rings around a nucleus. Despite its ominous name, it carries a better prognosis, reminding us that appearances can deceive. Closing. The art of diagnosis. These morphologic fingerprints aren't just academic, they're the foundation of accurate diagnosis. Is it clear cell or chromophobe? Prognostic stratification. Will it metastasize aggressively? Targeted treatment. Does it harbor MET mutations? In our next section, we'll bridge these microscopic findings to clinical outcomes, because in pathology, every detail matters. Delivery guide. Pacing. Slow for measurements, 315 centimeters. And percentages, 7,080%. Dramatic pause before revealing prognosis. Tone. Awe for gross descriptions. Striking yellow to orange. Urgency for invasive behaviors. Renal vein invasion. Hope for favorable prognosis. Emphasis. Bolded terms. Paranuclear halos. MET protein gene. Contrast clear cells' beauty with its aggression. Clinical features and staging of RCC. Renal cell carcinoma is a master of disguise, often silent until advanced, then revealing itself through cryptic clues. Let's decode its clinical language and staging secrets, where early detection makes all the difference. Clinical features. The elusive triad. Textbooks love the classic triad: hematuria, flank pain, and a palpable mass. But here's the reality check. This trio appears in less than 15% of cases, making RCC a notorious silent killer in early stages. When symptoms do strike, they're often indirect. Paraneoplastic syndromes that hint at the tumor's endocrine mischief. Polycythemia, from erythropoietin overproduction. Hypertension, renin's rebellion. Hypercalcemia, pH-like hormone havoc. Cushing syndrome, ACTH in disguise. These systemic effects turn kidneys into endocrine imposters, confusing clinicians and patients alike. Staging, the invasion map. Now the critical question. How far has it spread? The TNM system holds the answers. T. Tumor size matters, but so does renal vein invasion, a red flag for aggression. N. Nodes lymphatic spread whispers of advancing disease. M. Metastasis RCC's favorite destinations. In order. 1. Lungs, the bullseye. 2. Bones, lytic lesions await. 3. Liver and adrenal glands, silent footholds. 4. Brain, the endgame. Prognosis. The survival calculus. Here's the stark truth. Staging dictates survival. 100% 5-year survival if confined to the kidney. Early stage wins. Plummets to 60% with renal vein invasion. Dismal odds with distant metastases. This is why we obsess over early detection. That 100% isn't just a number. It's a life reclaimed. Closing, call to vigilance. Remember, RCC hides behind mundane symptoms and mimics endocrine disorders. But with astute staging and timely intervention, we can rewrite those survival statistics, one early diagnosis at a time. Wilms tumor, nephroblastoma. While adults fear renal cell carcinoma in the world of pediatric oncology, one name looms large: Wilms tumor or nephroblastoma. This is the most common kidney cancer of childhood, a disease of the young, typically striking between ages 2 to 4. Let's uncover its secrets. Clinical presentation. The pediatric triad. Wilms tumor announces itself with 3 telltale signs. 1. A large unilateral flank mass, often noticed during a bath or diaper change. 2. Hematuria, blood in the urine, a parent's nightmare. 3. Hypertension, driven by the tumor's rogue renin secretion. This triad transforms an ordinary toddler into a complex medical case overnight. Genetics. The chromosomal culprits. Behind this tumor lie genetic betrayals, most commonly deletions on chromosome 11, disrupting the WT1 and WT2 genes. These mutations can arise sporadically or as part of sinister syndromes. 1. WAGR syndrome. A devastating quartet: Wilms tumor, aniridia, missing irises, genital anomalies, and mental retardation. Children with WAGR face a 15% risk of developing Wilms. 2. Dennis-Drash syndrome. Even more ominous. Genital dysgenesis and nephropathy carry a 90% risk of Wilms tumor, demanding vigilant screening. 3. Beckwith-Weidman syndrome. Recognized by macroglossia, enlarged tongue, organomegaly, and neonatal hypoglycemia, this overgrowth disorder whispers a future cancer risk. Pathology. A gross perspective. On the pathology table, Wilms tumor is a large, well-circumscribed mass. But don't let its borders fool you. The cut surface reveals a battlefield of hemorrhage and necrosis, evidence of its aggressive growth. Closing, a call to action. Why does this matter? Because early detection saves lives. A child's flank mass isn't just a lump. It's a potential Wilms tumor screaming for imaging and genetics workup. In our next section, we'll explore how modern therapy has turned this once fatal diagnosis into a curable disease in over 90% of cases. Tumors of the lower urinary tract. While kidney tumors command attention, the lower urinary tract, especially the bladder, is a silent battleground where cancers thrive. Today, we'll expose the 2 major villains here, their risk factors, and how modern medicine fights back. 1. Urothelial carcinoma. The stealthy mimic. The undisputed champion of lower tract malignancies, urothelial transitional cell carcinoma, accounts for the majority of bladder cancers. Key alerts. Smoking is its prime accomplice, but occupational exposure to naphthalamine, think dye/paint workers, and drugs like cyclophosphamide also play sinister roles. Calling card. Painless hematuria. Blood in urine without discomfort, lulling patients into false security. A master of deception. Multifocal lesions often appear simultaneously, and shockingly, these tumors are twice as common as renal cell carcinomas. 2. Squamous cell carcinoma. The aggressive shadow. Less common but more ferocious, squamous cell carcinoma emerges from chronic irritation. Schistosoma hematobium infections. Endemic in Africa/Middle East. Decades of nephrolithiasis or chronic cystitis causing squamous metaplasia. Why it terrifies oncologists. Often diagnosed late due to nonspecific symptoms. More locally invasive than urothelial cancers, with poorer survival rates. Prevention and diagnosis. The life-saving duo. The battle plan against these tumors has 2 fronts. 1. Prevention. Smoking cessation cuts risk by 50% within years. Occupational safeguards for chemical workers. Eradicating schistosomiasis in endemic zones. 2. Early detection. Cystoscopy. The gold standard. A camera reveals what urine tests can't. Urine cytology. Catches exfoliated cancer cells, perfect for high-risk groups. Closing. A multidisciplinary war. These aren't just urology cases. They demand pathologists to grade tumors, oncologists to target therapies, and radiologists to track spread. United, we're turning the tide. 90% survival for early-stage urothelial cancers proves early action saves lives.